1998. They wanted to ascertain whether or not the positive effects of cognitive behavioral therapy remained after termination of treatment. In their original study, 87 participants were randomly assigned to one of three conditions: cognitive behavioral therapy with routine care, supportive counseling, which was unstructured therapy led by the patient with routine care, and routine care only. The cognitive behavioral therapy included coping strategy enhancement, problem solving, and relapse prevention strategies. 61 patients of the 87 were available to participate in the follow-up study. On slide 16, results showed that patients who received either cognitive behavioral therapy with routine care or supportive counseling with routine care maintained their levels of improvement across all outcome measures 2 years after termination of treatment. But patients who received routine care alone experienced a worsening of symptoms. Interestingly, there was no significant differences between the cognitive behavioral therapy and supportive counseling groups. This study does not bode well for cognitive behavioral therapy due to the fact that supportive counseling was once considered a placebo. The authors speculated that supportive counseling may have provided consistent, positive social interaction which would facilitate the decrease of negative symptoms. On slide 17, Terrier et al. In 2001 employed a similar methodology to their 1998 study, but this time they were looking at the responses of individual symptoms to cognitive behavioral therapy. Again, they had three groups: cognitive behavioral therapy with routine care, supportive counseling with routine care, and a routine care only group. On slide 18, results indicated that cognitive behavioral therapy is effective in reducing the presence of hallucinations and delusions. While cognitive behavioral therapy and supportive counseling led to equal improvements in delusions, cognitive behavioral therapy is most effective in treating hallucinations. Cognitive behavioral therapy also resulted in fewer negative symptoms and disorganized cognition than routine care alone. On slide 19, Barrow et al. In 2001 created an integrated intervention program for the treatment of patients diagnosed with schizophrenia and comorbid substance abuse disorder. This intervention program included routine care, motivational interviewing, which fosters motivation and responsibility in indifferent clients, cognitive behavioral therapy, and family and caregiver intervention, which educated and encouraged family members to adopt a motivational interview style. They compared the integrated intervention with routine care alone. The authors did not give details about the nature of the cognitive behavioral therapy, except that its goals were to reduce hallucinations and delusions. 17 participants were assigned to the integrated care group, and 15 were placed in the routine care group. On slide 20, results indicated that the integrated treatment program was effective in increasing functioning levels, reducing positive symptoms, and reducing the frequency with which drugs and/or alcohol was consumed. It is also important to note that 94% of participants completed the program, which suggests that it would be feasible to implement outside of the research setting. On slide 21, a study conducted in 2005, the researchers created two different cognitive behavioral therapy strategies to be used as a supplement to vocational rehabilitation and tested their efficacy. Computer-assisted cognitive strategy training consisted of three components: discussion of elements of strategies, repetitive practice of these strategies using hypothetical situations, and generalizing the strategies to novel situations. In other words, patients were being trained to adopt their work environment to accommodate their cognitive deficits with the use of tools such as labels or signs, schedules, and rearrangement of objects. Training of self-management skills for negative symptoms, which consist of the systematic replacement of negative symptoms with involvement in pleasurable activity. So for example, a client might be asked to take a photograph of a possible leisure activity that he might engage in instead of withdrawing and isolating. The study was comprised of 3 groups. The CAST group, along with vocational rehabilitation, the TSSN group with vocational rehabilitation, and vocational rehabilitation alone. On slide 22, results showed that the CAST with vocational rehabilitation yielded an increased capacity of attention and verbal memory, increased likelihood of successful job placement, but there were no significant improvements in planning ability. The TSSN with vocational rehabilitation did not invoke a decrease in negative symptoms, as was hypothesized. On slide 23, a 2005 study, the researchers conducted a study on the efficacy of cognitive behavioral social skills training with patients ranging in age from 42 to 74 as compared to standard care. Cognitive behavioral social skills training often involves role-playing activities that help the patient to become more comfortable in social situations and rehearse problem-solving strategies for use in difficult or unfamiliar situations. It also involves the use of traditional cognitive behavioral therapy coping techniques and strategies for overcoming cognitive impairments. 76 patients were assigned to either the cognitive behavioral social skills training condition or the routine care control group. On slide 24, results show that the patients who had social skills training performed social functioning tasks as effectively as patients in the control condition, but they performed the tasks more frequently. There were no significant level of symptom reduction. However, the researchers did find a positive correlation between cognitive insight and positive symptom reduction. On slide 25, a 2006 study, the researchers sought to identify the cognitive predictors of increased social functioning in schizophrenia. 85 participants were randomly assigned to either a cognitive remediation therapy group or a control group receiving standard or usual care. The cognitive remediation therapy group, or CRT, main goals were to improve cognitive functions such as attention, memory, and problem solving through individual sessions of intense, repetitive written tasks. On slide 26, results indicated that baseline social functioning was related to verbal working memory, verbal long-term memory, visual spatial long-term memory, and response inhibition. The researchers found that improved social functioning was predicated by schema generation, but this occurred regardless of whether or not the patient received CRT. They concluded that there was not enough evidence to conclude a straightforward relationship exists between social functioning and the generation of new schemas. The overall conclusions of this presentation are that, despite some flawed studies and methodologies, it is clear that therapy in conjunction with psychotropic medication is much more successful than medication alone in the treatment of schizophrenia. Cognitive behavioral intervention may reduce or eliminate the need for medication in some cases, thus effectively eliminating the possibility of harmful and risky side effects. The positive effects of cognitive behavioral therapy continue well after the termination of treatment, which is important for people with low socioeconomic status who can't afford continuous therapy. Family involvement in the patient's care can play a significant role in reducing relapse rates and rehospitalization. While the literature bodes favorably for the use of empirically supported treatment modalities, it is apparent that most facilities and institutions are not utilizing them. More research is needed to identify a treatment strategy that will be just as effective for the negative symptoms of schizophrenia.